Good evening, everybody. Thanks for dialing in, and I hope all of you are doing well and are keeping safe in these uncertain times. Before I begin, I would like to acknowledge the traditional custodians of the land that dialing in from. This is an acknowledgement of country, which is usually done before any event in Australia. And so I wish to acknowledge the traditional custodians as well as pay my respects to any elders past, present, and emerging. And I thank you all for being here today. Today's topic is on mHealth for healthy aging. This is, I think some of you might have attended last week's webinar by one of my WHO collaborating center colleagues, Myron, who gave a webinar on mHealth for integrated service delivery. So this is a different use of mHealth, and this presentation will focus on a systematic review that our team we did on use of mHealth for healthy aging purposes. And this is a subset of a broader review that was commissioned by the WHO Western Pacific Regional Office. And we undertook the main review in late 2017. So to get started with, what is mHealth? So this is the definition of mHealth that has evolved over time. So essentially, it was initially in 2011, it was defined as medical and public health practice supported by mobile devices. So any mobile technological devices, such as mobile phones, patient monitoring devices, personal digital assistants, and any other mobile wireless devices, such as fitness trackers, sensors. And this definition, initial definition, was by the WHO Global Observatory for eHealth, which does not exist anymore. But this definition was taken up and followed through. And in last year's WHO guideline, where this was the first set of guidelines released for digital interventions for health system strengthening, mHealth is defined as the use of information and communications technology in support of health and health-related fields. And thereby, mHealth or mobile health is a subset of electronic health or e-health and is defined as the use of mobile wireless technologies for health. So it is much more broader than just using mobile phones for healthcare purposes. And the ownership of smartphones, it depends on age, which I guess is because we have to be mindful that as people age, even normally, our cognition and all our senses start declining. And also, mobile phones were really not in use until about 20 years ago. And so the higher proportion of people who own them, as per a recent report from the Pew Research Center, apparently it's people within the age group of 18 to 34 years who own mobile phones, irrespective of whether they are in high income countries or low or middle income countries. So the context of our topic here, as in how aging and health are connected, as you can see in this slide, the global population is aging in most countries, even in Africa, and the proportion of people over 60 years is projected to be much higher by 2050. And as of currently, the proportion as of 2020, as you can see, is between 10 to 30% of the population in most countries. I mean, in a lot of countries in the world. And Japan currently has a leading percentage of older people. And the connection between aging and mHealth, this is because, first of all, as I said, the aging population is increasing among all countries, and the fastest rise has been observed, like real rapid increase in aging in the lower and middle income countries. This is because healthcare delivery and health services, as well as medical science and technology, has advanced quite well over the decades, and ensuring that older people have equitable access to essential, not essentials, quality healthcare is an important part of a universal health coverage, which is equitable access to healthcare, irrespective of one's socioeconomic status. And universal health coverage is a key aspect of the Sustainable Development Goals, and the WHO recommended initially in 2013 and then again in 2018. They recommended that mHealth is to be used as part of a whole of systems approach towards aging and health. And following the 2017 regional action meeting of the WHO Western Pacific region, this review was commissioned, and through a international contract awarded to the rest of the review team. And I managed this review and came on board to help complete the review on time. So, healthy aging. Now that we've talked about now that we've talked about what mobile health is and how aging is a significant population concern, and healthy aging itself is defined again by the WHO as the process of developing and maintaining the functional ability that enables well-being in older age, where one's functional ability comprises the health-related attributes that help people to be whatever they want to be, do whatever they want to do, uh, keeping in mind what they reason and what they value. So essentially lead the kind of life they want to as they age. And this is the definition of healthy aging as stated in the World Report on Aging and Health, which is the latest report that we have from 2015. And there are, according to this evidence-based framework from the National Aging Research Institute located in Victoria, in the state of Victoria, here in Australia, this evidence-based framework or determinants for healthy aging were developed by the researchers from that institute. And these 9 determinants are supposed to be what really covers every aspect of healthy aging. So health management, which is management of a person's health by their healthcare providers or their carers or themselves, self-management, as well as healthy eating, active living, and smoking cessation or tobacco-free living, and reducing harmful alcohol and drug use, and improving one's mental health, and prevention of violence and injury, improving one's sexual health, and age-friendly environments, which are really important as a person moves from just middle aging to aged, which is 65 years and above. So the objectives of the current systematic review were to identify a subset of good quality randomized controlled trials that have implemented different interventions for healthy aging, which fit in under the context of healthy aging, as we saw among from those 9 determinants of healthy aging. And also we aim to summarize this evidence from the good quality trials that have tested these interventions among older adults. So what I'm speaking about the findings that I'm going to showcase, some of the trials, they are from that subset of the broader review that we undertook. So briefly touching upon the methodology that we used. So we used the PRISMA guidelines for conducting systematic reviews, and we searched 8 scientific databases just to be thorough. And this was the search strategy that we used. So we used one subset was mobile health itself, the other subset was healthy aging, and we included aged care as well. And then the 5 tenets of the REAIM framework, which is a widely tested theoretical framework by Glasgow et al. And the 5 components or tenets of the framework include reach, effectiveness, adoption, implementation, and maintenance of an intervention, of a healthcare intervention. Um, and we also use the PICO framework, that is, which is used for assessing randomized controlled trials commonly. So patient intervention or population intervention, comparator or control group, and the outcome. So we included studies published in English from 2017 onwards. So since this review was conducted initially in late 2017, we decided to go back to literature from the past 10 years, and also 2007 was the time when the first iPhone was introduced. And so essentially when smartphones started existing, and there was this huge uh, um, scramble to buy mobile phones overall. And also, where possible, we limited the search criteria to adults aged 45 years and older, because since the population of the world has generally aged, and the lifespan of people, the average lifespan of a human being has increased from, so middle age is now 45 years and above. And just touching upon like how we included the good quality RCTs. How did we classify them as good quality? So essentially, as long as a study had a control group, at least one other group. So, and also if their sample size was calculated before the study was implemented a priori, and with a high power level and a high confidence interval. And as long as the study or the trial attained the estimated sample size. So this was taken from the National Health and Medical Research Council's guidelines. And we did a quality appraisal of the included trials using the critical appraisal skill program checklist for RCTs. And so for the purpose of the bigger review, we did our final search on 3rd November 2017. And then last year we updated the search so that because we started drafting, we were planning to draft the paper, so we updated the search to find latest trials. So I'll just take you through this diagram. So this is for those of you who've done a systematic review or are familiar with systematic reviews, you know that this is a Prisma flow diagram. And essentially we identified 3,820 records from using the selection criteria that we used to search those 8 databases, and we managed to narrow them down to 65 randomized controlled trials, which provided some quality of evidence, and further managed to narrow these 65 to 31 based on that sample size and confidence interval and attainment of the target sample size. So now just to showcase some of the trials, but before that, a very broad overview of 31 included trials which are to be included in a paper, which is currently being drafted. So, out of these, most trials, which is not surprising, were conducted in upper middle income and high income countries, and by geographical region. And there was one trial which was conducted in China and India, hence the number doesn't add up to 31 here. And also, if you look at the geographical spread itself, the majority of trials were conducted in Asia and Europe and US. So within Asia itself, there were 3 done in China, 2 in India. This includes one trial done in both the countries. And then there was another trial that was done in Philippines, Cambodia, and Congo. So that was done across continents, which is really good. And well, in this part of the world, there's only one trial in New Zealand. So going back to that framework that I mentioned earlier, 31 of all the 31 included trials. All of them addressed health management in some way, whether this was management, self-management of by the individual, or management by their provider, or a community health worker, or a carer. And they also overlapped with other trials with trials that were done for healthier eating and active living and tobacco-free living. And this was because we were only looking for high quality trials, we could not find any in the remaining categories. So we did find some feasibility studies when we conducted the broader review. We found studies in the mental health and age-friendly environment categories, but there were none in the preventing violence and injury and improving sexual health, and even reducing alcohol and drug use. So even pilot or feasibility studies were not conducted in these 3 categories. So now showcasing a few trials here. So one of them was this one was done in Jordan, and here there were 3 groups. So one group received daily text messages about their medication, their diet, and their smoking. Uh, and then another group, the placebo group, received just daily general messages. So the messages weren't tailored. And then there was the control group, which received routine care. And this intervention was based on a theoretical framework, the self-regulation theory. And the findings showed that there was significant difference between study groups, between all 3 groups, in terms of their adherence to their medication, which was really encouraging, and also adherence to a healthy diet, which is great. But there was no significant between group difference in intention to quit smoking or a number of cigarettes smoked per person. And the next one was conducted in Mexico, and this was to do with patients who had type 2 diabetes. And this was a randomized control trial called Project Dulce. Uh, and here there were 3 groups again, and the duration of the follow-up was 10 months. And the first group, that is the main group, main intervention group, Project Dulce group, received a USB-powered glucometer, a 3G mobile phone with mHealth app containing surveys, videos, and brochures. And then the other group, and also they also received text messages and weekly peer education sessions. So the Project Dulce only group, that is without the mobile technology, they received the education sessions alone. And then the third group, the control group, received the routine or standard care. So what did they find? They found that there was significant reduction in the glycated hemoglobin A1C, which is an indicator of diabetes, in the Project Dulce technology group. The participants in that group did better than the group which only received education sessions, and also better than the control group. So that was a really good outcome, and there was significant improvement in diabetes knowledge in both the intervention groups compared to the control group. So this goes to show that any kind of additional information provided is sometimes pretty useful and has a good effect on the participants. And the next study was again a randomized control trial, which had 3 groups, which had a 12-month follow-up period. And this was also based on a theoretical framework, the intervention. And one group received information-only text messages. Another group received interactive text messages. And the third group received usual care. So they found that there was a small reduction in mean systolic blood pressure compared to usual care. So there was a reduction in both the groups that received text messages, not just the interactive text message group. So another study this one was conducted in USA, and it again was a trial with 3 arms with a 24-month, a really long follow-up period. And here one group was the self-monitoring group using a personal digital assistant, or a PDA. So that was the mHealth group essentially. And then another mHealth group received daily tailored feedback on top of just the self-monitoring they were doing. And a third group received, they maintained conventional paper diaries. And this intervention was based on a theoretical framework as well. But there was no between group difference in mean percentage weight loss, which was the primary outcome. But there was significantly higher adherence to self-monitoring in PDA uses compared to paper diary group. So both groups which used mobile health technologies were better than the group that did not. But there really was no difference in the primary outcome itself, which goes to show that maybe that that somehow this intervention, the PDA and the PDA with daily tailored feedback, was not really effective. So the next one, the next trial was a 2-armed randomized control trial with a follow-up period of 1 year. And the mHealth intervention group received a pocket personal assistant for tracking health for self-support following lung transplantation. And the control group received usual care. So there was a significantly higher self-monitoring, which is really good, and also adherence to medicine, the prescribed medication regime among the participants, as well as increased reporting of abnormal health indicators among the intervention group. So essentially, this was a really successful trial, and also given that this is a really major surgery, it's really heartening to know that these participants in the intervention group had a good difference thanks to use of mHealth technology. And this is one of the trials which was conducted across two countries. So this trial was conducted in 27 villages in China and 20 villages in India. And it had a 12-month follow-up period. And here the intervention was delivered to participants by community health workers. So this was not a self-management like the previous studies that were showcased. So this was a trial where the actual intervention itself, which is management of the participants, was done by the community health workers who from both countries in the rural areas, and they used the Android powered app and to deliver the lifestyle interventions, which included uh, smoking cessation and reduction in salt intake, and also enhancing the uptake of two prescribed medications, so antihypertensives as well as aspirin. And 2,800, 2,086 individuals with high cardiovascular risk participated overall. And there was a significant increase in use of patient-reported use of their antihypertensive medication in the intervention group, which was much higher than the control group. So this showed that it was pretty effective. The trial was really effective in achieving the main outcome, and that community health workers play a good role in rural areas when it comes to delivering mHealth interventions for lifestyle changes in among older adults. So there's a few limitations of the review, which is that because we use this kind of methodology, the Prisma methodology for systematic reviews, because the search criteria is restricted and we cannot change it from database to database. So it's essentially the same search terms you enter, because that is important to do it in a systematic review. So we could have missed salient studies, important trials that did fit the context of healthy aging and mHealth, but were just not picked up by the databases. But that is always possible even if you do not use a systematic review methodology. Um, Heterogeneous nature of the included RCTs, as you could see from the few that I have talked about, that they were all, the mHealth technologies were used for very different purposes, and the different outcome measures that were used also were very varied. And hence, it's not possible to really do a quantitative analysis of this data. So we are stopping it with a qualitative synthesis of the findings. And comprehensive search, which we did, which is a strength, because we did a look at 8 scientific databases, and we did a little broad search in terms of not restricting the search terms to any kind of study design, or or as to what purpose an intervention was conducted itself. So even if there were studies which were picked up which were not really relevant to healthy aging, but then we were really thorough to make sure that we did not leave out studies as much as possible. And we also included two frameworks, not just one. So as I mentioned before, the REAIM framework and the PICO framework, while doing the data extraction of the included RCTs. And here are the take-home messages for everybody from our review findings. So most of these interventions were an adjunct, so they supported existing age-friendly health services, particularly for adults with chronic health conditions, especially diabetes, cardiovascular disease, including hypertension, and chronic obstructive pulmonary disease, and lifestyle changes, which again were important to prevent chronic health conditions. So the feasibility and usability studies, which we found, which were very abundant, were well designed, and they confirmed the positive attitudes. So essentially, participants, whether they're providers or whether they're the patients themselves, or people from the community, so they had high intent to use the health technology, as long as, of course, they could understand, they had enough cognition to do that, and there was good user uptake and engagement, and the rapid pace at which technology evolves. So in terms of development, in adoption and demise of mHealth apps, this is a real challenge, as everyone would know by using some sort of mHealth app, like a food diary app or a fitness app on our own phones. We would know that they just come and go, and how many of them are actually evidence based, how many have actually been tested, at least on a small scale as a pilot study. That really is something we need to consider, because as consumers, everybody is affected by this. And also, in terms of healthcare delivery, the patients, the providers, and policymakers need to be very mindful of this fact that there are just too many apps being manufactured, created, and then just spread out through the iOS or the Android systems. And there is a lack of conclusive evidence regarding the long-term impact, the sustainability, the cost effectiveness. So these are covered by maintenance tenet of the REAM framework. And also, this is important to recognize that we really don't have that much information on these aspects. So as to actually embed these kind of interventions as an ongoing tool for healthcare delivery for older adults, we really need to have more trials which have longer follow-up periods, and also have done a cost-effective analysis. So in the future, for everybody who wants to do mHealth research, it is recommended that they use the mHealth evidence reporting and assessment checklist, so the MERA checklist, which was published by the WHO Technical Evidence Group in 2016. So one of the main recommendations and one of the criteria of that checklist is that the mHealth interventions should, irrespective of whether they're used for healthy aging or other purposes, should be based on a logic model or a theoretical framework with use of appropriate behavior change theories. So we obviously did not use this checklist for our studies, because our search criteria included studies from 2007 onwards. So it is very important to know that this would be a good tool to use when designing or implementing studies, and not just research studies, but any mHealth interventions. And also for mHealth research itself in the future, there need to be more and more robustly designed trials, the randomized control trials, with which have a person-centered approach and include a biopsychosocial perspective. So this is not just taking into account the biomedical aspects of a condition or disease, but also making sure to incorporate the psychological and socio-economic status of a person. So it's better that they are interactive. And it is important that the interventions are tailored, because this is for any health management or self-management intervention. It's very important that it should be person-centered and biopsychosocial. So these also should not be just at the clinical or consumer level, but it also these irrespective of whatever level the mHealth interventions are designed for, whether it's at the system level or the service level or provider level and consumer level, we have to remember that these any mHealth intervention should be person centered and include this approach. And it's very essential that there are robust governance frameworks for mHealth strategies, because there is a big risk of fragmenting clinical practice, and this has implications for not just patient safety but also provider safety, because there way, as I said before, there are way too many apps being developed and used and then thrown away. And it's so important that for any health related intervention, it's so important that there are various frameworks at, again, the different levels of healthcare. So this was a handbook that again is, I I just would like to talk about, and so that everyone could be aware that there is this uh, handbook released by the WHO and ITU back in 2018, which is a handbook on how to implement mobile aging. So this is, it has different kinds of tools inside this handbook, because it's essentially a toolkit which has different recommendations on how to implement healthy aging in the community settings. So I'd just like to acknowledge that this review, the broader review, which our WHO Collaborating Center was commissioned to do, was funded by the WHO Western Pacific Regional Office. And technical support was provided by Ms. Kate Sylvan and Ms. Britta Bayer from the WHO WIPRO, and also Ms. Joyce Cornelius. She was very helpful in helping us determine the search strategy and ensuring that we did search the right databases for the systematic review. Thank you very much for listening.